So we will start our plenary session. It is a great pleasure for me to present to you a colleague from Saguenay-Lac-Saint-Jean, Marie-Eve Poitras, whom I have seen as a student in my research center. We're only a few years we have only a few years difference. Marie-Eve now is a nurse, was trained as a nurse and assistant professor at the University of Chicoutimi, and she's a researcher at CIUS in the Saguenay area and the Charlemagne Research Center on innovation in health. Marie-Eve is very much activated in the support unit for the patient, and I met her because one day she came and she studied the shared decision-making process, and I said, wow, this is so interesting. And after that, I did what I usually do. I talked her into coming into my field. So we have a little pilot project together, and it is very interesting. But her research group is from chronic diseases, and she's interested in the transfer of knowledge. So she will present to you her research. So, good afternoon. I'm very happy to be here with you this afternoon to talk about one of my professional passion, shared decision-making process. Cynthia mentioned it. I am very interested in how patients are involved in research, and this comes because I really want patients to be active in the decision-making process and that they become actors of their daily lives. I must say it's very humbly that I am here today because neuromuscular diseases, it's not my field. I'm first-line nurse, and I'm also a researcher involved in first-line research and services and health and changes in policies and improvement of skills improvement. So what I have seen throughout the day is that shared decision-making process, this is transversal for all clientele, all diseases, and all patients' population. So you can make links between what I'm saying today, what I propose to do in your clinical context. Also, what I wanted to mention is that it's most enthusing to see that you have researchers, decision makers, patients, etc. You're already 2 feet ahead of everyone because patients are involved, are present, they participate, they discuss with you, and it's not in all organizations that you will see that you will see such innovation in 2018. So I wanted to mention it. So choosing. What do we mean by choosing? Choosing is to compare various options, exert one's judgment, say what you will prefer, etc., in order to decide something rather than something else. So when we look at that, we realize every day of our lives, and that's going to be true for everyone, for the rest of our lives, and patients also must make choices. Majority of the time, choosing is like a long, quiet river where the decision is quite clear. We know what we have to do. We know our options. We know ourselves. And it's easy to make a decision because we feel it, we know it, the scientific evidence is there, and we're sure that it is the right decision. However, sometimes, in some situations, sometimes choosing is difficult. It's not easy. It's full of obstacles. It is uncertain. It is stressful. It is in these situations that we start feeling stress, distress, regret, and it can lead to depression and decisional remorse that can last years. When we must make a decision in the scientific literature, it is what we call decisional point. What is it that we're talking about today? What is the decision that we must make today between the clinician and the patient? What is the position? What is it that the patient must decide? What is the nature of the decision? When will the person have to make that decision? Sometimes we know we will have to make a decision in sometime in the future, but when exactly? And finally, what is the impact of this decision on our daily life? So first, we must know what is the decisional point. And what we see is with our patients, most times they don't even that they are actually in a decision-making process. For example, the choice of a molecule. The patient is just coming out of the clinic and we have a prescription. Well, that's a choice. The patient made a choice of a molecule more than another with the risk, advantages, disadvantages, side effects. The person will take that every year for years. But maybe the person doesn't even know what choice he or she has made. But so what should we choose? An investigation made by University of Ottawa in 2003, not too young. It's not very recent, but it doesn't change really. It's made for the general population. So with respect to birth control, sterilets, etc., institutionalization, relocalization, changing an environment. So I'm linking this up with some of the things I have heard today. Everybody will have to go through changes in their environment, pregnancies, birth, life habits, sedentarity, tobacco, physical activity, losing weight, better food, social activities, etc. All these are changes or options, decisions that we must make every day. And finally, all the tests, diagnosis, prevention, screening, etc. But when we must make a decision, we must find a balance between what I want, what is good, what the literature says, what my doctor says, and what my family wants. So we must play with all that. And when we make a decision, especially when we suffer from a multiple chronic or degenerative dizziness, maybe option B is not better than option B because scientific evidence is never 100%. So we must reflect. Choosing, is it that easy? According to you. Choosing, is it easy? Who thinks that choosing is easy? And there's no bad answer here. Who thinks that choosing is difficult? Who thinks that choosing it depends? Well, you're right. There are choices which are simple, but others are more complicated. As clinicians, we wonder, and as patients, we're not too sure. So choosing is a mixture of our values, our preferences, our personal experience, and the available knowledge. And I will often refer to that. Values, experience, knowledge, this is what will lead us in our decisions. I'll give you a common example. To decide to stop working or not. When we work with patients with degenerative or chronic diseases, they have a life, and often these people work, or they have activities that may look like a work. So one day they will have to think in terms of stopping their work or modifying their schedule according to their state. I work in certain research projects where we can see that values change, and sometimes it's the same option come up with different values. A person will say, "I'm really, for me, work is really important. It is important for me to contribute to the family income. I want to be an active member of the society. I think about my health first, and I want to have some energy to be with my children or my grandchildren." And finally, the question, do I really have a choice? It's 5 different values with the same decision. So what we see here, when we don't know what to do, when we have different options and we think about home, we don't really know what to do, we call this the decisional conflict. We have a hard time picking one of two options. We have a decisional conflict. We don't know. That's because we're not sure. We don't know if we should go forward, if we take option A, option B, and the decisional option, the decisional conflict, it has a lot of impact on everyday life. Separation, divorce is a good example. People who have to move their parents somewhere else. We are going through a decisional conflict. For the general population, we will all have to make difficult decisions at some time or another in our lives. What we do know is that most people involved in the decision-making process, for example, if I have to make a decision, people have an inadequate involvement in the decision process. And when people are not adequately involved in the decision-making process, when the patient is not, it has health issues, negative results, less motivation, anxiety, depression, less trust towards the health professionals, lack of commitment with respect to one's own health, and we can feel guilty with respect to the decisions we made. And all this has an impact on self-management, the way that people will manage their daily life. Regarding literature, it's quite clear. Those with neuromuscular diseases, this will amplify the complexity of the decision. If choosing is difficult for everybody, man on the street, but if you live with a chronic disease, more so if it's degenerative, the level of complexity will increase. I will illustrate what is this complexity. Often what I say to my students, it's that complexity is complex. Often when we have a patient with multiple chronic disease, it's multifold. If we have a disease, it can be complicated, but it's not necessarily complex. If we have a good self-management, good support group, it's complicated, but it's not necessarily complex. A complex situation is a mixture of all the conditions that I mentioned earlier, multiple disease, vulnerability, overuse of services, mental health issues. I was mentioning earlier Cynthia Gagnon talking about her DM1. We know that they have a lower social support than others, and they have also very often low income. So that adds to the complexity. And this complexity means that decisions are more difficult, they are multiple, and it's full of uncertainties. They are multiple because the patient sometimes can make 2, 3 decisions in the same consultation with the health professional. It is full of uncertainties as well because the majority of practice guides that we use for supporting us with our patients are oriented towards one disease in particular instead of looking at multimorbidity or the complexity of a situation. The statistics that we base ourselves on, the evidence to push an option or another with our patients, these statistics are useless for a complex patient, and the level of certainty increases, and option A becomes as uncertain as option B. For complex patients, decisions are similar to those in the general population. Modification of life habits, the choice of a treatment or an intervention, the level of care. And I insist with the level of care because it's not really looked at with great importance when we hospitalize a patient, yet it is a decision that is of great importance. There are consequences, many consequences, prescription of care. But the patient is not involved in this decision-making process. Job status, do I continue to work, as I said earlier, full-time, partial-time, part-time? The involvement in a program, you're all health professionals here mainly, but you should know that for a patient to commit oneself within an interprofessional team, ergotherapists, nurse, doctors, neurologists, etc., it can be a difficult decision.
Finally, think that the patients might have many health issues, difficult for them to prioritize the needs and to prioritize the problems that are important. In clinic, we ask them to prioritize. See, so that's very complex. As a clinician, we do our best. Sometimes we underestimate the weight of decisions for the patient. That means that we don't think that the impact are so important, the mental load for patients. What we do see in literature, some studies looked into specialists, physicians, how they would commit in a shared decision process with patients. What we notice is that clinicians are often use shared decision process who also are mobilizing their health. Those who are self-managed, they can manage this at home, they have resources and tools. We're talking about these patients. What we do know is that clinicians are more comfortable to go in a shared decision process when they are comfortable themselves with the scientific uncertainty level. When we don't know if option A or B, which one is the best as a clinician, you're not too comfortable to commit into that process. However, what we do know is that clinicians fail to discuss scientific uncertainties. It is not presented appropriately. We don't list options. Think about the literacy of your patient, mental fatigue, cognitive problems. We need to explain that to patients so that the decisions are taken according to their values. We often fail to present alternative treatment. Sometimes we don't know about them, but we say that we are comfortable with our own language, our own treatments, our options, what we know or what we can deal with in our daily life. So I ask you today, would we leave our patients alone with their decisions? Do we leave them climbing the mountain alone? Do we give them the proper tools to take the proper decisions? I don't have the answer, but I have examples. What we do know, in fact, that it's for a patient to change a behavior, to decide to stop smoking, to start a daily activity program, to eat better, to better manage risk. It's the most difficult decision. However, it's the most frequent decision they have to take. Remember, lifestyle, that's a daily change in behaviors. We know also that according to some patients, they think that clinicians underestimate their work status. We suggest patients, just stop working, change your status, just to go for a part-time job. They underestimate the mental burden of this, as if it was all so easy. We know that for patients, it's easier for them to take an antibiotics for pneumonia. You take it for 14 days, it's done. Then stop smoking and start doing physical education. So we don't support them enough in their decisions. As an example, their decision tools that help people to decide to take an antibiotic or not, but I didn't find any tool to help people choose to stop smoking. When a patient have to take decisions, there's a decision, the decisional conflict The decision conflict can go for days, weeks, and years. I tried to find the best way to illustrate what it was about decisional conflict. You are all artists. You are all musicians. You master your instrument, your practice, your activities, your language, and your practice guides and your recommendations. So you are Lennon, a pop singer, Hendrix, or Mozart. Sometimes the patients go in the clinic, what they find Lennon, John Lennon.
Pardon?
The next day, they go in the clinic and they find her.
La semaine suivante,
The next week, it's Hendrix.
Life was but a joke, but you and I, we've been.
et finalement,
And finally, Mozart.
voyez-vous,
You see, I'm pretty sure that each of you would say, oh, it's all complicated. All that music is complicated. But if you learn to play with practice, you can play that music. So complicated becomes manageable and easy. But what happens when we include complexity with our patients? If each clinician gives its advice, talks its own language,
And this is not our thing. So let us stop talking false.
donc c'est ça.
so this is the decisional conflict for the patient. We hear the notes, but no music. There's no melody behind. You don't remember the pros and cons of option B. They're confused with option B. You don't know which music has weight, and you remember the language that is the easiest to remember, but is it the best? Decisional conflict happens when the decisional support is not appropriate, when the right information is not given to the patient, if they rely on media or parents. And it happens also when you have a low psychosocial support. Those people who have no network, no family, no spouse, or sometimes you have a family, but they don't give any support. And decisional conflicts happens when there's social pressure. When there's a pressure concerning some choices like breastfeeding, the social pressure is very strong. When social standards favor one option rather than the other, when time for reflection is limited, when patients, we ask them to take quick choices, think about a medical consultation, you see the patients 10, 15 minutes, which screening, which molecule, which professional. When explanations are vague and conflictual between professionals, very often we all have the good intention, but our messages can be perceived differently. And finally, when the patient doesn't know well the consequences and the patients and the options. Some categories of people can be more at risk and others more protected from decisional conflicts in literature. That's a recent study in 2016. People living alone of more than 45 years old, low level of education, well, lower than average, and men would have higher risk of decisional conflict. Now, I'm talking about gender. Some studies say we need additional studies to show the difference as far as the gender is concerned. But there is a trend in literature. There are some protection factors, like the fact of having a family doctor, or I'm thinking about the case managers, like senior nurses, patients can have a better feeling about the decision. We know that some patients already have access to services. They are within the professional team. They have some level of services already in the current system. They are protected. And those with an experience in the health system and a positive experience, those with a negative experience is the opposite. They are at risk of decisional conflict. What can we do? I'm convinced that shared decision process is the future of patients and members of interprofessional team. That's all part of the patient-focused care. One approach is support to shared decision. Why? Because patients, multiple chronic disease are all the heart of an interprofessional team, and decisions, as I said, can be of various nature. Decision support can be from the physiotherapist, the nurse. It depends on the nature of the decision. So what is a shared decision? Shared decision making is when we have to present various options to the patients, and scientific evidence for option A from option B are identical. There's no best option. It is also when we see that patients are not comfortable with the current process. They need to be supported to help them decide which one is the best decision for them. So shared decision is taken in all options, whether is one option, more than one option that is foreseen. Shared decision is also very efficient. It was shown among vulnerable patients. And remember, vulnerable population are those that are not interested by that process. So it's complex. Those with a good self-management process have a good decision process that is shared. And those who are vulnerable are not, but they would benefit more from that shared decision process. And the shared decision is a process that can be taken over a few days, months, and even years. The patient has to take choices. There are always a few choices. When we have only one option, it's also a shared decision, shared decision making, because the choice of deciding now, status quo, well, it's a choice for the patient. Very often we minimize that option because if we arrive, we offer one option and he doesn't choose that option. We think that he's resistant. We think that the patient doesn't want to choose. He's denying and he doesn't want to go forward. No, he just wants to stay as he is right now, and it's about status quo. Shared decision-making involves reflection. We have to leave time for the patient to think about it, to just think about the different options, to see what is the best for him, and to get also information available and to come back with the proper decision. If the patient is in a shared decision-making process, he has to take into account the options, the advantages, the risk, and impacts. Sometimes there's no scientific evidence. Before coming here, I did not do a systematic review of literature, but I looked for the needs in terms of a shared decision. I didn't find any study on that specific topic. I was not surprised because even with my frontline chronic disease patients, I don't have, but they are making daily choices. But we don't have the scientific evidence to help them in their decision. Finally, there's no shared decision if options presented to the patients are not proposed according to their values, preferences of the patients. If we don't take into account his values and preferences, it's not a shared decision-making process. For patients and also clinicians, if we are in that shared decision-making process, the best decision for them is a happy balance between evidence-based data, the preference of the patient, and the values. If we have all three of these, well, already it is a process of a shared decision, and this process varies from one person to the other. Not everybody reacts in the same way to a decision. There are three types of patients clinically. You'll probably recognize your patients here. First, we have those who want to control the decision. They are the ones who say, give me all the information, I'll go home, I'll read that, and I'll get back to you. They're comfortable in control. They want to have the lead on the situation. And we have those who want to share. Those who ask our opinion, discuss, and we see that there is discussion. There is a mutual responsibility, and they want to have that. This is the kind of discussion that guide them in their decision. And the third one, those who would prefer to let go. What would you do if I was your daughter, if I was your mother? What would you recommend? So they put the decision back in the hands of the clinician. There's no best behavior. We're all human beings, and I can be controlled one day and let go the other day. It all depends on the nature of the decision, of the difficulty of that decision, and where we are in our life, our knowledge, our experiences. When a patient has a bit of control, that's okay, but we should provide the right information when he asks it and ensure that he understands the nature of options presented to him. For a patient who lets go, we have to respect that as well. Some parents will never be able to take the lead depending on situations like organ donations. When families have a difficulty, they just let go. Well, our role as clinicians is to validate values and preferences of the patient, to take the decision with his agreement and in line with the values, preferences, and needs. Working with a patient that decides to let go the decision, it involves that we have to know that patient. We have to get into that professional relationship and know him better. It's a mutual commitment to offer the best option. When we have a patient that is committed, dynamic, asks questions, wants to share, our role is to provide information, discuss, and validate his knowledge. Shared decision-making process is divided in 6 steps. My reference model is the Ottawa decision model that was created by a team at the University of Ottawa. The first step is to clarify the decision. In clinic with the patient, you don't take it seriously. We don't clarify. But what is it about today? What is the decision that you have to take? Oh, today, Mr. Simard, I meet you because we have to change about the change in the environment. You have to name things correctly and put the right words on decisions patients have to take. When we filmed meetings, clinicians turn around the bush and, it's not giving a service to the patient not to name things properly. So we have to speak clearly and assess the level of understanding. We base ourselves on literature. Adapt to your language, adapt to your arguments according to what his literacy is. Then, number 2, the assessment of decisional need. Where is that person in his decision process? There are 4 categories of step, depending on the step you are at in this reflection on options. It will guide the decisional conflict you will face. It can happen. Some patients don't think about the options, and not thinking about the options, that's not about status quo. It's just not to think about the options. They don't want to hear about it. For example, people don't think about the level of care and say, oh, well, I'll get at the hospital, I will decide. Or relocation, well, when I'll get there, I'll take the decision. Well, people who don't think about the options are at a high risk of decisional conflicts. They risk to reduce the time between you have to take the decision, and this reflection time is very important in the decision-making process. Some people actively think about the options. You will recognize they ask questions as the neighbor, the cousin, and family members to make up his mind, read on internet, and come up with sheets of Wikipedia, and they were very active. But a person who's active and talks to everyone is someone that is not comfortable with the decision. He's not comfortable with the various options. He asks everybody around. We say he's fishing around, so he has a high risk of decisional conflicts. Very often we have to bring back the reflection and offer the best scientific evidence to revalidate the values and preferences and to limit taking information at the neighbor, going on forums. Not the best way to think about it. Now, the other two levels, those who are ready to take that option, they have done that reflection. Our role is to look at that person. Is he receptive? Is he ready? Did the decision was taken according to his own values? Is he under social pressure from his support network? So we just check that everything is okay. And finally, some are already in action. They choose, and it's okay. The decision has been taken. They are very comfortable. The risk is very low of a decisional conflict for these patients. The third step is assessing and identifying the realistic expectations of patients. We show the benefits, risk, options. They read and they come back. Very often they have expectations, realistic expectations for side effects, but also for positive impacts. Think about parents where we start medications for attention deficit. I think it will change the behavior. School scores will improve, but we have to put them back to reality. Same thing here. What we have to look for are signs, verbally or body language. Maybe the expectations are not realistic. Examples of expressions we found in this treatment gives cancer to everybody. False belief. I know someone that it worked for that person, so it will work for me. Your treatments never work for me. Everything you tried with me never worked. Why would it work this time? So it's a realistic expectation, but negative one. What we have to do is to see why they have this kind of expectation, what makes them believe, for example, that this treatment gives cancer to everybody. Well, my sister-in-law, and we need to demystify this, to try and give them better tools and make them understand the risks and benefits of options. There are 3 techniques you can do clinically to demystify unrealistic expectations and support the patients to try and make it more in accordance with their values. First is clinic counseling. It is used for people where they are still thinking about the options, to go through the 6 steps I'm going through today to support the patient in his decision. Second option is to put some framework around his reflection. They are thinking about changing behavior, but very often they step back, not sure anymore. What you have to do is to validate why they chose that option first. Remember, when you chose such an option, you prioritize such a value, situation, environment. We looked at such a document. Now, is it still okay for you? So you just reposition this when the patient needs it. Is it about scientific evidence? Did he read something else? Because the spouse is not sure and he feels the same. So we try to go and see where can it went wrong. Finally, we have the decision-making tools. Could be papers, videos, case studies, images, any media you can use to show the patient through pictograms what are the scientific evidence concerning the treatment and options. These tools allow, with scales 1 to 10, to identify values and meanings of things. Going to work, is it important for you? Side effects, nausea, is it important for you? Out of breath, is that important for you? And according to what is important for the patient, you can propose the best option possible. And the knowledge transfer scale, this decision-making tool is the most efficient to transfer scientific research to the patient. Very efficient also to help clinicians explain concretely in an easy way what is results. What are the research results for the patients?
Then we have the fourth step in decision-making. I put a pink drop that represents values for me. Values are intrinsic to everyone. My values are not yours. They are not your partners, your family, or children, for example. At that point, we need to validate with the patient what is important for them. Some value the children or family, that their decision will be based around these. Or some will prefer having a safe environment. Different values to base their decision on. So then we need to validate with patients what is important and to give them the opportunity to have a say. At that step, you should see it as a way to better understand your patient. And knowing their values, here I'm talking about the case managers or interveners, well, then you can transfer these to the team to relay the message that for Mr. Smith or Simar, well, they prefer this value. As an inter-team, then we can better support patient's decision-making, and we are consistent in our support to the patient. The fifth step now. The fifth step is at the time when we look at the patient if support was sufficient or if something else can be offered to support decision-making. If there's informational support, did the patient have enough information, books, websites? Because the patient needs to go back home with something in their hands. This needs to be also popularized and adapted to the literacy level. A second support, we should look into if there's professional or personal support in decision-making. Is family supporting them, helping them adequately, not thinking that because the patient has a partner, that the partner necessarily supports them in decision-making. We need to validate the role of each one of them. For example, a question to ask, what is your role in decision-making? Or what is, according to you, your partner's role? The role of your children as part of that decision, and what can they do to help you make a better decision as part of this? So we need to validate. If the patient does not have enough informational or personal, professional support, our role is to bridge that gap, and that does not really depend on me, for example, but I need to find the right person, the right case worker, the right information to give him what is needed. Sixth step, follow-up and progression. A decision lasts over time. We make a choice for the rest of our life for most of cases. and we need to validate whether it will last. If the patient is comfortable on the next day, in a week, in a month, if the patient is comfortable with it. Clinically, there's a 4-question tool to validate if the decision process has been made adequately. And if we didn't miss anything, the first question we may ask the patient is, are you sure that of what your best options are? Yes or no? Do you know the risks and benefits of all of these options offered to you? All of these including status quo. If you choose not to get a surgery today, if you choose to not change environments or not stopping to smoke or physical activity, here's the risks and benefits of status quo also. Clinically, benefits and risk of status quo is sometimes not looked into enough or overlooked. Do you think you know what is best for you also with regard to risks and benefits? With that question, then we can look at values. Sometimes we may have 10 positive aspects, but 1 negative. The negative one is perfectly consistent with our values, and we'll make that option a no choice because it is the most important aspect. For example, moving with the children, or having the children have to move. Lastly, did you have enough support in making a decision? By support, I mean professional, informational, and personal support. If the patient answered no to one of these 4 questions, that means that something somewhere was not done adequately. So maybe the options were not properly presented. Maybe we didn't introduce risk and benefits of all the options. Did we clarify what their values are? Did he have enough support? What I would like you to keep in mind is that patients who need complex care, who have to make multiple decisions, they are oftentimes frequent and severe. Because of their conditions, this complexifies their daily routine. The patient lives with that condition every day, every hour, however you want it. This complexity adds a layer to that decision making. The patient does not know what to do because option A might not be better than option B, and scientific evidence is very low for vulnerable patient. The preferred approach, especially for chronic patient, is shared decision making. The best decision to make for a patient is the one that is linked on evidence-based practice with the best evidence, values, and preferences. If clinicians tend to underestimate scientific evidence and oftentimes underweight values, we tend to talk about statistics, but patients like to hear about preferences, values, and what's important. I'd like to remind you that life is not waiting for a storm to pass, but rather to dance under the rain. Our role as a clinician is to help him choose the music, dancing shoes, and the rhythm. Thank you.
On va avoir le temps pour les questions vu qu'on est en traduction.
Sometimes for questions. If you have questions, you can go to the microphone before moving to the question period. Tomorrow morning we have included breakfast. It will be served starting at 7:30, I believe, 8 or 7:45. Then we have happy hour, the happy hour following this session with, if you have a blue ticket, there will be also a tribute, a segment, and then a little celebration. But before, do you have any question? Well, I do have one. Marie-Eve, you introduced decisional conflict from the patient's perspective. I've had a short clinician's career, but I'm sure that you're not always comfortable with the options presented, and then within you have a preferred choice for patients. How first do you notice this, and how do you also not become biased with regard to our own conflict and saying this makes no sense that we're offering this to patients? I'm sure that this happens to you. I'm offering this, but I find it makes no sense. Or it really makes no sense. All right, well, thank you for your question. It's true that in literature, it is well documented that clinicians, we are in decisional conflict with regard to options that are offered. This leads to inadequate popularization of our concepts. So optimal decision making was not met in that case. Also, clinicians experience this very bad. For example, if a clinician offers options that he doesn't like, for example, is conflictual, not evidence-based, the next clinician then will also keep this in mind and have bad thoughts about it or afterthoughts. Decision making is for clinician and patient. When both are a part of a transparent, popularized decision making, this lowers conflicts and prevents what we called regret, decisional regret. Decision-making tools, the last media introduced to you to support decision, is one of the best platforms to use because clinicians are not alone in their office and saying, I hope that such an option is better. We have something tangible, and even if scientific evidence are not at 40%, for example, well, at least it's supported by something. We are not bearing the burden of this decision, making an easier decision for everyone.
J'ai manqué un peu le début, là. Peut-être que j'ai...
Maybe I missed the presentation, but I don't know. In using this decision-making approach, how much time does it require? I guess it evolves over time through sessions and our knowledge of the patients. So that's my first question. Also, as part of a multidisciplinary team, is a one person better position to do this, to support this patient as part of the decision-making process? Thank you. I'm happy to be able to answer these questions. Research was conducted, not me, but teams I work with. They looked into normal consultations and shared decision-making process. And this decision-making process requires 2 more minutes. Decision-making, this process, well, it depends on the nature. A relocalization, for example, as part of a home care, we can spend an hour and a half with the team and with the patient and family. For a new molecule, well, maybe just 15 minutes. It depends on the nature of the decision. That when it's heart-wrenching decision, the time you take more, 5-10 minutes, well, you gain time because you have less decisional regret after. Does this address your question? Yes, all right. Well, now second question. Who can do this? I will say it depends on the nature of the question. If it's with regard to a molecule, it's a more medical-based decision. If it is part of a case management program, life habit changes, new plan, well, this is the interdisciplinary team then should be involved. Why did I introduce to you those 6 steps and these tools? Because it is the role of every professional to see if people we are taking care of, if they are in conflict or decisional regret. If there's a decisional conflict, I need to clarify when. If it deals with, for example, not really knowing my right options and risks and benefits, then I can hand over the patient to the appropriate worker, and then we can come back to it. As part of the multidisciplinary team, we need to be aware of decisional conflict and then direct the person to which worker they should go to. Thank you. Just to piggyback off my previous colleague's question, within a team, there are different perspectives on the user-partner approach, also perspectives on level of autonomy, on the capacity to manage risk for themselves or others, always as part of a good conscience. Should we reach unanimity within a team before offering a decisional process if team is not really on a consensus? I present to you the Ottawa decision-making process, but also there's an interdisciplinary process. Based on interdisciplinary process, the inter-team needs to know options offered to patients. If it's a case worker appointment, we need to discuss as a team about the options that are offered to the patient. If it's a problem that is systemic, if it's only a problem that deals with social work or nursing, well, it's only a profession-based decision. If there are disagreements between decisions, we need to first agree as a team to see which option we offer to the patient before we offer them ourselves. When we ask questions to patients, do you see disagreements? How do you perceive disagreements? We think that patients do not realize that we have disagreements within interdisciplinary teams, but it's one of the biggest factor of perception of quality of care to patients. When you work as an inter-team, when we are facing a difficult decision with a high potential of difficulty, then we need to agree. If they are evidence-based and we know patients' values, I think we can go more practically, more solo. Once again, thank you, Marie-Eve. And most likely, and that symposium will have neuromuscular decision-making tools, I guess. Maybe something else. All right, so you're all welcome to happy hour. We'll have the activity. If you haven't found your partner for photo booth, try to find your match and take a photo, and then go back to Marie-Hélène. Oh, and please bring back receivers at the back for those who had a simultaneous translation. Enjoy your happy hour and see you tomorrow morning for breakfast.
Excellent. Vraiment, 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 vraiment.